so much, Jennifer. And Luis, I will ask when you're not, and Joe, when you're not speaking, if you can mute just to help with feedback. Awesome. So I do want to say that I feel completely unworthy of this, but Joe, Luis, and Emma all convinced me to come and be a part of this, and I couldn't say no. So I will be giving some of my perspective, but from my perspective, these are three of the leaders in the state, if not the country, on harm reduction, and have so much lived experience, work experience to talk about, and how important this area is to save lives. And that's what it's really about at the end of the day. So we're all going to start with offering our own definitions of what is harm reduction, sort of a level set, but a level set that is actually really hard for us. We've been having this conversation, and you'll hear at the end of this, we are in a work group. If you're interested in getting involved, let us know. We have trouble coming up with this definition. But we are going to share what harm reduction means to us. And also, when everybody introduces themselves, if they can just say a little bit about themselves and where you work, and how you are brought to this conversation. So I will start with Joe Turner, the Executive Director of Exponents, and my friend. Thank you, Joe.
Hi. As for that friend stuff, right back at you. Hi, Allison, Emma, Lewis, and all of our friends that join us. I'm Joe Turner, co-founder and CEO of Exponents. Exponents is a 30-year organization. You know, we got our footing early on in the 80s, dealing with the HIV/AIDS situation and how that intersects with people that use drugs. And we just said, hey, we couldn't wait for folks to get abstinence before we shared this life-saving information. We didn't call it harm reduction then. You know, we just met folks where they were. We said, come on in, you're welcome, no judgment, no blame. And we've grown since then. And Exponents now has grown from it started out in a men's shelter, sharing the day room with guys that were sleeping, and we were talking about bleach kits and those days. And now we have about 14 different programs. We're also partnering with Housing Works to do syringe exchange. Yay! We're putting our money where our mouth is. And as well as recovery. And so that's, and I'm glad to be here with Lewis, Emma, and of course, Allison.
Joe, so let's do those intros first, and then we'll get into the definition. So Luis, muted Luis.
Hello, everyone. Louis LeBoy here. I am the Director of Addiction Services for Emma L. Bowen Community Service Center, located on 145th in Amsterdam, Sugar Hill, where we're providing a continuum of services for individuals from 3 years old to very old age. We have a therapeutic preschool for 3 to 5 year olds. These are children with behavioral and academic needs, and we get them ready for public school. We have outpatient mental health services for children and adolescents, 6 to 18 years old, as well as adults. We have a community residence, an Oasis 820, a 20-bed facility in Spanish Harlem for 10 men and 10 women, seeking recovery and transition to self-sufficiency and independence. We also have the outpatient addiction treatment services, where we are providing medication-assisted treatment, telehealth, ambulatory detox for mild to moderate symptoms of withdrawal from alcohol and opioids. We are an overdose prevention training program where we provide free training to New York State with the naloxone kits for free. And we have a pantry and a case management service as well. And at this time, we have partnered up with several harm reduction agencies like the Washington Heights Corner Harm Reduction and the New York Harm Reduction Educators, where we do extensive outreach as part of the community access network with the SOR2 grant, where we are outreaching 125th Street and Lexington Avenue hotspots, also Washington Heights and the South Bronx. And we're proud of that. That's what I have. Oh, I'm also a part of the New York State Alumni Association, the steering committee, and the chairperson for the Bronx Council on Alcohol and Substance Use Disorders. Thank you.
Thank you so much, Louis. And Emma of the Evergreen Health in Western New York.
Thank you so much. My name's Emma. I use she, her pronouns, and I'm the Associate Vice President of Harm Reduction here at Evergreen Health in Western New York. We have offices in Buffalo and Jamestown and a mobile unit, some mobile services that go out into more rural areas in the western part of New York State. It is a unique honor, honestly, that I get the opportunity to share space with you all that are doing this work across the state. I frequently say harm reduction, embracing harm reduction and working in harm reduction has changed my life, but also being able to just share space with folks like Joe and Louis and Allison, who are really, championing meeting people where they're at across the state is a pleasure. So, just really quickly, what I do in particular here at Evergreen Health is I oversee our harm reduction services for people who use drugs. Some similar things that Joe and Louis already mentioned. We have some very busy syringe exchange programs these days, outreach programs, a lot of HIV and hepatitis C testing and linkage to care, a heck of a lot of Narcan training and distribution these days, and low threshold buprenorphine, which has become a big deal for us, getting people connected with low threshold buprenorphine when they need it most. And sometimes that means really lessening the requirements for them. So, and a lot of conversations about managing use and using safer going on in our area these days. Our geographic area has been really impacted by the spike in overdose deaths. So, that's it for me, and I will pass it off, but really looking forward to the conversation today.
Thanks so much, Emma. Yeah, we have so much to talk about, and so we will jump into that definition piece, and I was going to send it right to Joe, but I'm going to start just saying that we are, when I thought about, what definition could I bring to the table, I wanted to bring SAMHSA's definition of recovery, which, that's what sort of brings where this conversation is about the intersection of harm reduction and recovery. And, I think it has sort of been an underlying sort of struggle, but there's been a change. There's been an evolution in the recovery movement to start to embrace that harm reduction model. And I hope that this conversation helps to demonstrate that. So I'll start with SAMHSA's definition of recovery, which is recovery is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. And I like sharing that definition because I think everybody can kind of fit in that boat, and it doesn't mention anything about abstinence. It just, talks about self-improvement, and, we're all kind of there. So I like that definition because it feels very inclusive. And so now I'll pass it to Joe to share his beautiful definition that we've been developing.
Well, thank you, Allison. I just want to say I want to thank you for your work for New York, and the unique ability just to navigate so many issues and bring clarity to them, but also support to the harm reduction community. I know of the work you do, and the world should know it. So I just want to thank you for your love and sacrifice. But that definition of recovery from SAMHSA really nails it. I remember when it first came out, I was offering people $20 to find drugs or abstinence in there. And the focus, of course, as you said, was on wellness and health. So with harm reduction, and I think if we had a later discussion, you could align and just line up, the wellness as the principles of recovery and the principles of harm reduction, and they would align. But my definition, not my definition, it's a compilation of the hard work.
1 second. Luis, can you please mute?
Yes.
Okay. All right, Lucy. See those Yankee fans? All right. But my definition is just it's a combination of the SAMHSA definition and also the work that's coming up from the ground. And that is, I see harm reduction as an umbrella term for evidence-based practices and interventions that reduce the harms associated with drug use. And the key is evidence-based. This is not ideology. It's not, preaching and lecturing, but we're looking at the data where harm reduction does save lives, it reduces disease, and it promotes health. And it goes on to say that this framework does not minimize the dangers associated with substance use, but we have to recognize such factors as structural and systematic racism, poverty, class, and social isolation, trauma, mental health issues that influence health behaviors. They not only influence health behaviors, but they aggravate overdose deaths. And we cannot, at this time, it's my belief, treat substance use disorder in a vacuum, in a silo. That all of these factors, we're living in a society where they intersect and they affect wellness. So lastly, it goes on to say that harm reduction works to dismantle the structural barriers to health and wellness, as well as through advocacy building, community, and direct action. And I'll talk a bit later how advocacy is really a part of the DNA of Exponents and many organizations, and has been seen to help individuals lead a self-directed life. So the goal of harm reduction is not absolute abstinence from drugs. Rather, the goal of abstinence is the embrace of safety for people who use drugs, as well as a self-directed and holistic engagement with wellness for those who choose that path. So it's a lot of words, but I think the focus is on, we used to say, running into somebody in the street, they would say, well, how you living? And I think that is the focus here, that we're looking at how is your life, looking at the constellation of wellness, and we believe that harm reduction is a vehicle to get there. So that's it in a nutshell.
So yeah, I added those words to the chat. They're not set in stone, but it's something that we're working on. All right, and Luis.
Thank you, Allison. I want to also thank you for all the work that you have been doing all these years, especially coming down to the Bronx every once in a while. You have so much courage to do that. I thank you for that. Friends of Recovery New York really do care about all of New York State, and I appreciate that. And I go, wow, Joe, that was great. That was a great definition. So I'm a person in long-term recovery, right? I got 23 years that I haven't used any drugs or people. And this is my definition, coming through the system myself, right, of treatment, prevention, and recovery. So to define harm reduction, we must look at it as part of the continuum of care. Addressing addiction treatment and support begins with harm reduction, continues with harm reduction, and ends with harm reduction. Harm reduction is for everyone that is affected by the horrors of addiction. It is not an alternative to abstinence. It is a major catalyst into prevention, treatment, and recovery. Harm reduction techniques can be used at any point of contact to plant a seed of hope, recovery, change, improvement, growth, always striving towards increased safety and health. Harm reduction is reduced pain, anguish, and increase in love for humanity. Harm reduction is a basic human right. And that's my definition.
Thank you so much, Luis. It's impossible to choose one. So I appreciate everyone bringing their definitions to this. And I don't know if Emma has anything to add, because Emma has given us so much in putting these definitions together. So yeah, let us know, Emma.
Really quickly, not to take anything away from the definitions that have already been shared, but I'm not an executive director, but I wonder if Joe and Luis begin their staff meetings with speaking as passionately, as you both just did, because I know that would make me pretty energized and motivated to get to work. But that, is part of the amazing thing about harm reduction is it's passionate. It's part of who we are. And so I just want to acknowledge that it's like powerful to hear you both even give a definition of harm reduction. Not to detract anything from those beautiful definitions, but in the past year or so, some of our directly impacted people here in Buffalo have been saying that harm reduction equals public health plus social justice. And I think that that's really interesting. And I like saying that harm reduction equals public health plus social justice. I think when I think about the term social justice, I'll just say that I think about the social justice movements are acknowledging that the distribution of resources, wealth, power, privilege is not equitable in our society. And for me, that's a big part of especially what I see in the overdose crisis. There are a lot of social, biopsychosocial, but especially social reasons why people begin to use drugs and continue to use drugs. And if we don't have a systemic element to our treatment that acknowledges the role that social justice has to play, then we're not doing a complete job. So public health or harm reduction equals public health plus social justice. I like that these days.
Emma, that's the first time you shared that with me, so I'm excited about that one. Awesome. So I did want to share, and I talked a little bit about the recovery movement's growth to be more inclusive and to incorporate harm reduction. And thank you for that shout out, Luis. But I couldn't do anything without the people that I work with and the advocacy that gets done. And some of that advocacy is right within our network, is just, sharing stories and talking about how harm reduction works. So I did want to say that, one of the things that we are trying at For New York, we've started these conversations between prevention and recovery. Because, I think even within our field, there's a lot of learning that needs to go on, and there's, we need to share those experiences. And so we're hoping to grow, to start to incorporate treatment and harm reduction as well. Because, I know it's cliche, but I really believe that we're stronger together. The more that we, can get on the same page and talk about how we're working toward those same goals. So do let me know if you're interested in getting in joining those conversations. Our next one is actually November 8th. So my first question here is for each panelist, and it is, what does harm reduction look like in your practice today? What are the successes and challenges, and what is needed to fill those gaps? So it's a big question. So who wants to start? Anyone excited to start? Emma, you talked a lot about some of the work that you already do. So, do you want to talk at all about those gaps?
Yeah, absolutely. Let me kick us off. So I oversee our harm reduction services for people who use drugs here at Evergreen in Buffalo, in the western part of New York State. And what I didn't mention earlier is that I also collaborate a lot these days, recently, with our on-site OASIS licensed and OMH licensed services. So it's an ongoing effort, to have a perfect continuum of care that meets people across the stages of change. I like to talk to our staff about having a toolbox that's got lots of different tools in it. That's what we are as harm reductionists. And so, some of the successes is I'm proud to, I think in New York State, we have a number of places that are embracing this approach towards having a continuum of care. And so I'm proud to have been part of that here at Evergreen over the past several years. Having all these different licensed programs under one roof. I've realized that when I was in graduate school many years ago, I remember people talking about people who use drugs as a hard to reach community or a hard to reach population. And I've found actually that when you give people tools that they need, it's actually quite easy to reach people. And our programs are quite busy here in Buffalo. We have over 100 people come into our syringe exchange every day, which is quite a bit for Buffalo. And in Jamestown, it's a kind of a rural area, and we have about half of that, maybe around 50 people coming in there every day. Even though we're part of a larger organization, Evergreen Health is a federally qualified health center, we have a really down-to-earth approach towards working with our clients. So we celebrate them even showing up. Like if somebody comes in to our syringe exchange, I have my door open just a little bit all the time, and I see or hear someone that I haven't seen in a while, I make the biggest deal about them being there and say, genuinely, it's so good to see you. How are you doing? I'm so glad you're here. Why don't you just come in and have a seat in my office? I'll go get whoever you're looking for. And then if it's appropriate, of course, I might put my hand around their shoulder or shake their hand and just really celebrate the fact that people are here. We want people to feel really valued. And so that's a success right now. Despite the drastic overdose crisis that we're seeing in Erie County, people are coming in. They're continuing to come in at a pretty steady rate. On the flip side, one of the most significant challenge right now is the significant prevalence of fentanyl in our drug supply. Of course, a lot of us know at this point, it's not only what people are buying in the community as opiates that tend to have a pretty significant prevalence of fentanyl in it. But right now in Buffalo, and I know this probably hit New York City earlier, but in Buffalo, it's methamphetamine, cocaine, benzodiazepines to a certain extent. And that's really dangerous for us here in Erie County. Overdose rates during 2020 increased in Erie County 60%. And in Niagara County, which is a small county just north of Erie County, they increased 80%. Chautauqua County, just south of Erie County, they increased 70% during COVID-19. So a lot of that's due to fentanyl in our drug supply. And I really, these days, unless we really embrace harm reduction interventions, spaces where people can come in a low threshold, walk in non-judgmental way and be loved and be valued. And maybe that involves being supervised when they use drugs. Maybe that involves drug tracking equipment, probably all of the above. Unless we really start to decrease stigma and embrace these innovative approaches, I really don't know, to be honest, how we're going to significantly curb these overdose deaths. And I really hope that we start to see things like the opioid settlement funds go towards some of the low threshold harm reduction services that we're talking about here today, because that's where a gap is. It's a major gap here is in funding and embracing the innovative approaches.
Thanks so much, Emma. Great response. Joe?
Yeah,
I see you on the edge of your seat.
Emma set it off. And Emma, I love the hand on the shoulder, that radical welcome. We do the same thing here at Exponents. You know, one of our sayings, not a saying, is that we're on the 8th floor. So we say that for our receptionists, that for everyone who gets off that elevator seeking services, that they see in their eye, the eye of recovery, no matter what condition people come in. You know, you see them beyond their present circumstance. And I think that's one of the essences of harm reduction is engagement. Joyce Rivera, who, you know, has a great program, St. Anne's Corner in the Bronx, she defines it as mercy, you know, that being able, you know, I know there's a fancy term, patient-centered care and all of that. Maybe they're a little afraid to say harm reduction, but, you know, that is the approach. It's a philosophy. It's a way of seeing the world. And here at Exponents, we have instilled that into every program that we have. We have a harm reduction drug treatment program, you know, where we say to help with toxicologies. I mean, what's the use of a toxicology? You know, let's believe people, you know, let's show a sense of trust and collaboration with them through this process. And it's where they want to go in the process. We have a recovery center. We have a GED program, a harm reduction GED program. And what is that? It's engagement. It's engagement at every point of this journey here at Exponents. And I think that some of the challenges that we're facing again is, you know, I love the point, Allison. I would love to make one of those meetings in terms of collaborating with the other modes, with the other modalities of prevention and treatment. But even with that, we have worked recently with a major legacy abstinence-based program that was experiencing overdoses in one of their facilities, 2 and 3 at work. They didn't know what the hell to do. So we said, look, let's put down the ideology. Let's work together. Let's do a harm reduction staff training. We'll bring our van. We'll do syringe exchange in the parking lot. Okay, you don't want it in the building. We'll do it in the parking lot. We'll bring our van. And we are seeing tremendous results where we bridge the divides between prevention, treatment, and recovery and harm reduction. So with Exponents, the philosophy is from the front door through all of the services of meeting people where they are, but not just leaving them there, but engaging them, and just providing the environment. We don't empower anyone. We just provide the environment for folks to lead that self-directed life. So I blame Emma for getting me excited. So.
That's great. And there's a couple questions coming in, so I do want to bring your attention to them, but I want to hear Luis's response, and then we'll get to those questions. So go ahead, Luis.
Right. So our program at Emma Bowen is a little different because we're actually treatment providers and focused on recovery. We have evolved a little more different. We're not abstinence based. We're more sort of, we meet the clients where they're at, right? And we engage them and motivate them and encourage them to seek safer ways of consuming substances. And we retain them a little longer. You know, we do take toxicologies, but it's just for us to, you know, have an open discussion. Most of the time, the relationship we develop with the clients, they'll honestly let us know what's going on. Because when they come into the treatment part of our program, they really are seeking some kind of change, whatever it is, whether it's to reduce treatment or to stop to reduce use or to stop using altogether. We have gotten support from OASAS staff on how to develop treatment plans using harm reduction models instead of abstinence-based. So that's what we're focused on right now, meeting them where they're at. So we're looking at, this is something that was zero tolerance in the past. You know, if you gave us a positive urine 20 years ago, you was getting referred out automatically. Not anymore. Now what's happening is that we meet them where they're at, and we tend to retain them longer. They stay with us longer. And believe it or not, Joe, some people will start to change maybe after a year of treatment, only because they're witnessing changes from other people that's occurring within our unit. So embarking in that ideology, we have become an opioid overdose prevention program. We're also starting to, we're going to be issued fentanyl strips to give out in our outreach efforts as well. And we have a really good relationship with the harm reduction agencies, right? Washington Heights Corner Harm Reduction. They are remarkable at what they do because they got support from the schools, the Department of Education, and the community and the politicians in the community, where I don't see that in the South Bronx, right? And I go with my peers to the harm reduction agencies, and we provide sandwiches, we provide resources, a lot of attention, love, and resources to these individuals, and we just educate them and encourage them and let them know, listen, services are available. 90% of the time, what they're looking for is not what I have, but we have this one door, open door policy that there's no wrong door. So we'll refer you to wherever else you need to go to, whether it's housing, legal, welfare, or whatever it is. We have referral sources for them. So there's no wrong door. And this is something that the staff at Emma Bowen has been evolving into. You know, there was a time when an individual from the street would come in and they would take one look at them and say, well, he's looking for Louis LeBoy. But it's not like that anymore. Now it's like, come, you're welcome, have a seat. How can we help you? Would you like a soup? Would you like a sandwich? How can we help you? And the good thing about our program as well is that we have a CCBHC fund where we can treat people, you know, that do not have insurance, people that are undocumented. So we're able to pay for their treatment, medications, you know, so this is welcoming for the community as well. So I do appreciate what we're doing as far as focusing on harm reduction, and that's what it looks like. The challenge for us right now is that all my life, I'm 61 now, I've been wanting to open a program in the South Bronx. I'm from the South Bronx. You'll hear the sirens in about 2 minutes. And I want to open a program, and the community is rejecting me. The community is rejecting me. And I've been doing outreach out here for 20 years since I've been in the field. And it's odd, you know, and I think it was someone was talking about never giving up. And, you know, I'm going to have to go a little step higher, you know, and really advocate for simple things. And, you know, this is a hot spot for overdose with fentanyl and other drugs, but yet what we need is more programs, whether it's harm reduction or treatment. We need more. The population is growing real quickly in the South Bronx, and the people that are moving in come in with a lot of issues, but we're not expanding our services. The services stay at a level that they cannot meet the demand. So here I am willing to join, and I'm getting rejection. And I know that happens with, you know, we walk around the neighborhoods with our shopping carts, with our needles and cookers, and we got people telling us, not here. You know, and all I'm doing is giving out sandwiches most of the time. And they'll tell me, no, not here. And that's a challenge for us here. Our biggest success is definitely collaborating with harm reduction agencies like NIRE and Washington Heights Corner, and joining forces and understanding one another and focusing on the population and the community's needs. Thank you.
Thank you.
If I could just say, he struck on a developing point, is that we are experiencing pushback in a number of communities, Central Harlem as well as some parts of East New York, pushback against direct harm reduction services, fentanyl strip testing, syringe exchange programs, and that the New York State Harm Reduction Association, and especially Tracy Gardner from Legal Action Center, is taking the lead on developing a compassionate response to this pushback. So I'm going to get you the information, Lewis, and maybe we can get it to For New York as well, in terms of engaging some segments of the community. And a lot of time it's communication, it's language, it's seeing that our interests align, with preserving the community and saving lives. So I'll keep you posted on that.
Yes, please. I appreciate it. It seems like the main interest is, the bottom line, property values and things of that nature, and investments that people are making that kind of want to push us away.
Well, I know you all know the stigma is real. And we see it even, on our recovery center calls, people looking to put up recovery centers getting pushed back. So yeah, I'm glad you're sharing this with us. And I saw Ashley said in the chat, let us know how we can help you. So yeah, let's help you out any way we can. And a lot of that is the sharing stories and personalizing it. So there's been a lot of questions that came in the chat, and I think some of them sort of revolved around, how is recovery and harm reduction, how do they merge? And I think there was a lot of support in the chat also for that peer work. And Luis, you talked about working with peers, and Joe, I know you have a training coming up that Exponents is putting out. So maybe if you want to talk about, what is that intersection between recovery and harm reduction from your perspective?
Joe, can I start 1 second? I'll lead you in. So I just want to say that in the recovering community as well, such as self-help groups are developing policies as well. It's been historically challenged, where a lot of people in recovery kind of reject people that are actively using, because self-help groups are abstinent based. And what's happening now is that they're becoming a little more open-minded to welcome those individuals. And as a group, whatever group you're attending, that group has the authority on how to address individuals that are coming in that are still using, whether you want to trust them to be part of the structure inside that group. So that movement is coming along, chipping away little by little to help individuals become open-minded and more supportive towards the individuals that are in the recovery journey. Recovery, you're in recovery when you say you're in recovery, right? I remember when I was in treatment, Joe, I stopped using. I went down from 10 bags a day to 2 bags a day. And I was so proud of that. And my counselor said, "You messed up. You gave me another dirty urine. You're out of here." And I was so hurt, so I don't do those things anymore. I'm more open-minded. Go ahead, Joe. Joe's got something real good for our peers in the street.
Well, not as good as your spirit, Lou. I'll tell you. Like Ashley said, anything we can do to help. We want to see the Louis LeBoy Center of Harm Reduction right on 149th and 3rd. So
3rd Avenue.
Yeah, that's right. But it's hard work. So thank you so much, Louis and Emma. I want to get out the way of Emma too, so she can contribute. But at Exponents, we have developed a 12-hour harm reduction peer training to address some of these issues that Louis has talked about in terms of engaging the community, engaging folks that are using drugs with respect and dignity, providing choice instead of judgment and blame. And we've launched this at this time when where we see so much direct services from providers towards people who are using drugs, as opposed to the punitive, get the hell out of here practices of the past. And we think that it will be, it will bear fruit. But, in terms of recovery, we see harm reduction as moving recovery from the self to the family, and then eventually to the community. It's like turning recovery outward. And I think once we do that, then we see that recovery is actually a gift that brings obligations that transcend the self. And I say that because years ago, when I was in treatment, they were giving drinking privileges to residential treatment centers. I remember my first, my first weeks in there, I hear these residents coming up the steps, half drunk and everything. I asked my room, I said, "What's that?" They said, "Oh, they have drinking privileges." I said, "Wow, this is nice. I can't wait to get drinking privileges," which they swiftly suspended while I was in the middle of treatment. But we see harm reduction as a gift that not only affects me, just as problematic drug use affected my family, it affected it deeply. Some of you know what I'm talking about. And it affected my community. That the beauty of harm reduction, we see it as making amends to the community. And how do we do it? By seeking social justice. And how do we do it? By lose efforts on the streets every day, giving out sandwiches, giving out fentanyl strip testing. So I think with that philosophy of turning it outward, it reminds me of, there's a great saying that came from the Native American community. There's a program called Wellbriety, and one of the sayings is that the individual, the family, and community are not separate. They are one. And to injure one is to injure all, but to heal one is to heal all. And I think that going forward, that holistic, community-driven approach is going to bid us success and sort of mitigate some of that opposition that Lewis talked about.
Thanks, Joe. Emma, would you like to respond? And I also had a question in there about a definition of what you meant before about low threshold.
Okay, yeah, I can certainly touch on that. Thanks for that. That's a good question. Thank you. Yeah, I'm not, in these spaces, we should try to use as less jargon as possible. And I'm guilty of using some jargon like low threshold sometimes. So I'll define that. And one thing that's on my mind today about the conversation between the intersection of harm reduction and recovery is, in addition to working in the field here at Evergreen Health, I also teach a course on substance use at a local university at Buffalo School of Social Work. So students who are getting their master's. And this one assignment, it's a pretty old school assignment. Most people who have gotten a master's or a bachelor's in any type of helping profession have done this assignment that has to do with attending self-help meetings, like getting approval from a host or a facilitator to attend some self-help meetings, and then writing some sort of reflection paper about it. So for my class, the paper's due in a week or about 2 weeks now. And so students are sending me all kinds of questions. Well, I can only find NA or AA groups. What do you mean I have to attend at least one group that's not an NA or an AA group? Because, AA and NA groups have helped a tremendous amount of people in my life. I also know that model doesn't work for everyone, especially immediately, like people who are early on or still in some active use. That model isn't a perfect fit for every person. And so I love when students who have a lot of anxiousness and nervousness about writing the paper, I actually read the paper after I've encouraged them to turn off the computer, just go attend a harm reduction works group, attend a smart recovery group in your community, shut the computer off. You got to get out and go to this, get some proximity with people that are directly impacted, and compare that to the AA and NA experience. I love reading those papers because I think it really helps them see early on, before they go into the field, that different things work for different people. There are a lot of different, I think for New York is actually famous for saying there's a lot of different pathways to recovery. And we have to teach people, we have to teach professionals that early on. I think a lot of our people in all of society, professional or not, we have been taught that drugs are the problem in our communities. And so people do go into this field, whether they're getting their master's, whatever, thinking I'm about to go to school to learn how to get people off drugs or get people to stop drinking or whatever. And sure, that's the goal for a lot of people. I mean, we don't minimize the harms associated with substance use, especially chaotic substance use. But people, there's a lot of different ways to live safe lives of being in recovery. And I think I just wanted to acknowledge we got to teach professionals that early on. And that includes, in educational settings.
Thank you so much, Emma. And, that is one of the questions that we've also, seen in the chat. How do we make this change within our community, within our field? And I love that point about getting there into that educational setting, while people are new to the field and are just learning. I think that's a really great place to start. Did anyone want to respond to that? And I could go on to our next question.
Allison, did you want me to touch on the low threshold piece?
Yes.
It's only going to take 1 second.
Yes.
This term low threshold's become a little bit of a buzzword in our field, but that's okay. That's a good thing. Low threshold has to do with reducing the amount of barriers, lowering the threshold. A threshold's like an entryway. A threshold is something like a door, or I think of a hurdle that one has to jump over to obtain something, to achieve something. Low threshold services are a big part of harm reduction. We've got to have some easy entry point that's not requiring a whole lot of people in order for them to receive some healthcare and some support. So low threshold buprenorphine has become, I think, a big deal here in New York State, rightfully so, because it has to do with recognizing that we can't mandate a whole lot if we want to save lives. We can't mandate everybody goes to counseling. We can't mandate that everybody has a negative toxicology screen every time they come in. We can't, all these other things that we used to require of people in order to access buprenorphine and methadone, we've got to lower the threshold for. So I hope that answers the question a little bit. Again, I think of a threshold as something like a hurdle or a door, and doing low threshold work is really recognizing that we got to make these barriers as small, as minimal as possible.
Yes, absolutely. And those barriers too are those social determinants of health, right? And I saw Luis mention, overdose consumption sites, and also, I'm saying it wrong, but supervised consumption sites and recovery housing. Luis, did you want to talk about some of that, the important, like how that fits into harm reduction?
Right. What's going on right now, we see that other countries are doing so much better with harm reduction, especially because they do provide safe consumption sites. And today we heard on an earlier panel, we heard Ashley mention harm reduction housing. You hear that, Joe? That is amazing, because I was trying to put them together, and I'm thinking of a shelter with a safe injection site across the street, and Ashley came out with a harm reduction housing. So what's happening is that we have a lot of people in the South Bronx across the street shooting up in front of the kids, the public. The police isn't doing much about that right now since COVID, but the thing is that it continues to increase. And the number of people that are shooting up in front of you, is all you got to do is drive by and you see it, right? And we're not the only community, but also in Philadelphia and Brooklyn and other places. It's obvious that we need safe consumption sites, or you might call it something else, right, Joe?
Well, the point is the same. You're absolutely right. If you look at the data, and again, not the ideology, because folks are using, they're screaming these headlines, people are shooting up in public, and that's causing a bit of this pushback as well. But if you look at the data of these overdose prevention sites, not one overdose fatality has happened in any facility. They also reduce bloodborne diseases. And, my good friend of mine, Van Asher from Housing Works, he says, look, we don't know what the hell is the big, hoopla about this. We already have places where we can go consume our drugs. Everybody knows your name, put money in the jukebox, and they call them bars, right? They're safe. You consume, you go home. So I don't mean to minimize it, but you're absolutely right. I think the just the drama and the headlines of people shooting up in streets is because we know it's because they don't have places to go. There's no engagement, but that's being used by reactionary forces to rail against harm reduction, to rail against syringe exchange, to rail against fentanyl strip testing, medication-assisted treatment. So that's a great point, Lewis.
I did see something in the chat that said, how does harm reduction work? And I think we just have to look at this data, that shows that this is saving lives, and we are in a crisis right now, and we need a large, comprehensive approach. And so I appreciate sharing about that, and that is absolutely meeting people where they're at. And it's important also to talk about my next question, how does racism against Black, Indigenous, people of color communities inhibit recovery? And what can we do to holistically promote community healing for everyone? And I know this is also something, Joe, you're going to be talking about on our amazing plenary tomorrow morning. But this is something that we have to be real about, how, really racism and racist structures contribute to harm reduction or the lack of harm reduction services that are available. Do you want to start, Joe?
Absolutely. Traditionally, and if you go back several years back, decades back, when someone went into treatment, very rarely, if at all, did you interrogate the role of racism and systemic barriers in terms of treatment. But now when we look at the reality, problematic drug use, overdose deaths, in combination with COVID, disproportionately impact people of color and Black people especially. There's no analysis that cannot include mass incarceration, structural barriers to inequity in terms of inhibiting recovery. It inhibits successful treatment. And if we continue to look at substance use disorder in a silo, we're going to continue to have overdose deaths, which disproportionately impact people of color. And I haven't even talked about the criminalization of drug use, which in essence means the criminalization of Black people. So, I was teaching a KSAT class, and they said, well, what does racism have to do with substance use disorder? I said, everything. In this country, everything. We even going back, looking at some of the residential treatment, Black and brown people were discharged from treatment disproportionately to white residents under the term administrative discharges, or under the term not amenable to treatment. But if you looked at the reality, most of the patients, most of the clients, not only had to deal with the substance use disorder, but they had to deal with criminal court cases. They had to deal with other issues, foster care. The intersection of these issues impact substance use disorder and its treatment and its recovery. So that's why in any term, in any type of solution-driven discussion, we have to address the issues of race, of structure, of systems that hold people back and hurt certain people more than others.
Thanks so much, Joe. Luis?
Excellent, Joe. Yeah, I just think that the racism breaks people down in a dehumanizing pattern that results in drug use, domestic violence, criminal activity, social unrest. There's no doubt in my mind. So I agree with Joe. What do we do, Joe? What do we do to resolve this? What kind of continuum of care? How do we break down these barriers and move forward?
I just want to say years ago, and all of you are too young to remember, but there was a push afoot in some of the legislators, this around the 70s and 80s, that when certain legislation got close to an enactment, that there was a commission set up, and it was called to look at the racial impact that this legislation may have on marginalized communities. And when we look at some of the regulations coming out from OASIS, Office of Mental Health, wherever they may come, I think that type of analysis also might even, the playing board as well, because some of the consequences are unintended. For example, something as simple as in methadone maintenance programs, the take-home policies are built on distrust. Methadone cannot be prescribed, but yet buprenorphine can be prescribed. And you wind up with 2 tiers of medication-assisted treatment. If you think of methadone, and Lou, in the cities, you think of people standing online in Black and brown communities, standing online to get medication that they're not trusted to take in home. In terms of buprenorphine and Suboxone, you go to a doctor's office. And I think those practices are facilitating and proliferating 2 disparate systems, even in medication-assisted treatment. Hence, a disproportionate impact on poor people, on Black people, on brown people. So
I agree. And I like Angelia's comment, integrate anti-racism structural practices into treatment approaches on purpose. Nice.
I like that she added on purpose. I will just say as briefly, as someone who identifies as white and identifies as middle class currently and was raised that way. And although I have some working class history in my family, I think my experience has primarily been one of middle class. I didn't go into this field like directly thinking it was going to have a lot to do with race and class. I mean, I knew that was going to play some role, but the whole thing has to do with race. Everything we're talking about for the past 59 or 60 minutes has to do with race and class. And I think being impactful in this field means, as a white person, calls for me to do a lot of work on myself and a lot of work on my privilege. And it's ongoing. It's probably never going to be finished, but it's got to be continual. And for people who identify as white that are part of the conversation today, I would look up folks like, I mean, we could name a lot of great authors here, but I'll say in particular, folks like Michelle Alexander or Brian Stevenson and Carl Hart, even Maya Solovitz and Johan Hari, who identify as white, because we've got to be, as white people, doing our own work if we're going to make an impact on structural racism and the overdose crisis. COVID-19, the overdose crisis, and racial equity are one and the same. A lot of intersections there. They're not separate public health crises. And God, I just really am thankful to have been part of the conversation today. And I'm so glad we're digging into this stuff publicly at this point. It's sad that we've gotten to the point where we're at with this overdose crisis. And a lot of the immense amount of insurmountable amount of racial injustice in our country, but I'm glad that we are talking about it openly and publicly at this point. So thank you for New York. I mean, this is important.
Thanks so much, Emma. And I just, for my what I have learned and the time I've been on this earth, I do speak it, and I'll be quite honest here. I have so many white friends. Some are on this call right now, and they've suffered the worst loss imaginable, that they lost a child. And I think the question comes up like, well, where does race fit into this? I lost a child. I'm a white person. I'm a middle class person. I have resources. And, my thinking of it is maybe not that we put enough resources in today, but if we had put enough resources in 30 years ago, we might be in a very different place right now. But because it wasn't impacting white people at that time at the same rate, there wasn't the kind of investment that was needed. So my hope is just that the investment is being made, and that people of color are coming to the table and sharing what the needs are. So we have one more question that was on our agenda, and we have 10 minutes left, but the question was for us to think broadly. We get on the treatment calls, and treatment is talking about harm reduction and working on it. Do we believe that treatment has accepted harm reduction philosophy in their practice? So we want to ask us, and we want to know what the audience thinks as well.
Well, they'll accept the money, I'll tell you that. You got to be careful of all these harm reduction shingles being hung out with the expecting the opioid settlement funds coming in, and I'm serious about that as well. I believe, and I think it's been expressed on this call, that we really believe that harm reduction is applicable at every point of the continuum of SUD. That is dealing with prevention, interests. And I know I want to applaud you, Allison, for also talking to the prevention people, treatment, as well as recovery. And I don't mean to be, I'm not cynical, because I have seen some genuine efforts coming from the treatment community. I outlined this partnership that we're doing with this huge abstinence-based program. They're doing it because they don't want people to die, and I respect that. And they've opened up their facility to us, and it's genuine. So I think future partnerships like that will emerge. And I think if we get away from the ideology and just deal with the data, we'll be able to strike even more of these collaborations that work. We gotta keep talking to people. I've been on these calls also with traditional legacy, treatment organizations, and we've talked about harm reduction and how it applies. Exponents, we have begun training, staff trainings at harm reduction at traditional based abstinence agencies, and we found some receptivity there. So I'm hopeful. I'm hopeful that we'll get together in the future.
Exempt. But let me tell you, but I do notice these things, right, Joe? I can't understand it myself, but I think that it needs to change. You need to be included in this, right? We need to include you in here. I'm in a team. I shouldn't be saying this, but I participate in a collaborative with the state opioid response team, right? In New York City. There's 22 providers involved here. Prevention, treatment, recovery, no harm reduction. I'm the closest that gets to harm reduction. That's why when you told me that you was doing that new training, it would be perfect for these peers that are joining in that don't work for me. Thank you.
Thank you so much, Luis. Emma?
I don't have much to add. I mean, Joe, how many committees or working groups are we on about this question? You know, don't our treatment systems already do harm reduction?
You're right, Emma.
You know, harm reduction, it's our call to action when it comes to harm reduction in New York State, I think can be broken down into a twofold thing. First of all, we do need to bring more traditional, already existing treatment providers along. We got to do some training. We got to be talking about racism. We have to be talking about what it means to be white in doing this work. Some of the things I named earlier. Of course, we have to be doing training and education, bringing harm reduction into treatment. We also have to seriously fund and make sustainable low threshold harm reduction services, spaces and communities where people can come in and be themselves and get some basic things to take care of themselves, have somebody who cares about them and says hello and remembers their name and their birth date, even though they didn't have an appointment and have to give over their insurance card to come in, feel valued, that builds trust and rapport, and that leads to people engaging in ongoing services. It just does. Think about, I mean, this isn't a perfect example, but businesses like that I frequent in my life, the dry cleaners that's a couple blocks down from me, I go to on and on because they know me and they treat me like a human being. I know that's just a small piece of doing this work, but it's like people who are earlier on in the stages of change. And now people who know me have been sick of hearing me talk about the stages of change. I wish everybody were in the action and maintenance stages that comes into our workplaces. Our jobs would be very easy. I'd leave every day at 5 o'clock. There'd not be a lot of stress. But the reality is that most of the people that come into our settings are in pre-contemplation, contemplation, and the preparation stages. And people move throughout those stages based on what's going on in their lives. So it's not just about training the existing treatment system. We have to get serious about funding harm reduction in this continuum, funding spaces, expanding syringe exchange programs. There's like 25 syringe exchange programs in New York State. There ought to be 150, to be honest. And so, no, we're not there yet. It's not just about training the workforce. It's about embracing innovative approaches in funding syringe exchange, Narcan.
Awesome.
I could go on and on, but I'll stop there. I mean, I guess we could go on and on.
I know we could
all
go on and on. And I definitely wanted, and I know, like you said, Emma, we're on all these work groups, but you know, if anyone is interested in getting more involved and lending your advocacy arms to this, I will provide my email address and you can contact me and we can keep working together. Joe?
Yeah, Allison, if I could just give a plug to the New York State Harm Reduction Association. Emma is on the executive committee, and it's a relatively new association. We've been together for about 2 years. It's a collaboration of agencies upstate, downstate, and our sole purpose is to present harm reduction as the preeminent approach to substance use disorder. And that involves advocacy. It involves speaking up. It involves the notion that we're stronger together than we are alone. So we've conducted trainings. We have a website. Any information that you would need, we'll get right back to you. But I just want to let you know that there is a statewide association. We're not in competition with ASAP. We stand alone. And please contact us and we'll get to you. Thank you. I'll put the website in the chat.
I put it in, Joe.
Cool. Thank you.
Yeah. Luis, any final words you want to?
Thank you. I think we had a great session. Emma, you're amazing. Thank you so much. I am so happy to be here with you. And Joe, you continue to be my mentor. Allison, love you. Thank you, everyone, for attending. It was a wonderful conversation. Very insightful. Thank you.
Thank you so much, Luis. Joe, anything else?
As Lou said, love you, Emma and Allison. Everybody that tuned in, thank you so much for the comments. They were encouraging. And I think we're all gonna, when Lewis has the grand opening of his own agency, I mean, that's gonna be a party, so.
Yeah, definitely.
Yeah.
I'm all invited.
And Allison,
Awesome.
you do God's work. Thank you so much.
Thank you so much. I love working with you guys. And we will get, Joe, you sent us that training. We'll get it into our e-blast. So anyone who receives the 4 New York e-blast can get more information on that. And, the 4 of us are not hard to find. Keep in touch with us. Let's keep this work going. And thanks to everyone for chiming in the chat too. I hope we got to most of the questions, but if we didn't, then you're going to have to join our work groups and keep this conversation going. So thank you all so much. Great job.